Right, and good morning, colleagues. Thank you for joining us for the Medicines Optimization Learning from the Pandemic sessions. My name is Mojgan Sani. I'm the Director of Medicines Optimization at North Tees and Hartlepool NHS Foundation Trust, and I have the great pleasure of hosting this session with you. I have my colleague Sandy with me, who is also supporting me in terms of watching out for your questions at the end of the session. So just running through the objectives, we have a couple of objectives for our sessions this morning. Firstly, to reflect on the pandemic and the impact it had on health and social care services with respects to medicines and pharmaceutical services. The second is to have an opportunity to share our learning from COVID and the challenges we've experienced, and finally celebrating our success. We know that medicines are the most frequent intervention in the NHS and they save lives. So as you can see from this slide, we have a fantastic lineup of presenters on a variety of topics for you within the Medicines Optimization session. For example, we'll be talking about clinical strategies we've employed within critical care, the clinical trials, experiences from the Nightingale Hospital in London. We'll be sharing with you a research study from our researchers around people shielding at home. We'll be talking about the support we've provided to care homes and the impact on the community pharmacy services. We've also invited the Chief Executive for International Pharmaceutical Federation so that she can share with us some examples across the globe and some of the learnings. And finally, it's my pleasure really to share with you a video that's been put together by our multidisciplinary colleagues from Kent and Medway prehab team on the support that's being provided for cancer patients whilst they've been waiting for treatment. So as you can see, hopefully you'll enjoy the sessions. Great lineup of presentations and speakers for us today. Before I hand over to our first speakers, just a couple of three reminders. Firstly, we would really welcome your questions. Sandy and my colleague will be trying to combine them all together for speakers, and we'll have an opportunity to share those at the end of all the presentations. Secondly, please mute the computers if you're not speaking. That would be really helpful. And just a reminder that this session will be or is being recorded. So thank you so much again for joining me, and I hope you'll enjoy the sessions. First session is around clinical strategies within critical care settings and the trials, and I'm delighted to welcome Reena Mehta, who's the critical care lead pharmacist, and also our consultant intensivist, Dr. Rohit Saha from King's College London, who will be sharing their experiences with us. Over to you, Reena.
Can I just interrupt just for one moment? We're currently seeing not only the slide that you want us to see, but we're also seeing your next slide. You get the idea. There you go. Perfect.
Okay, over to you, Reena. If you let me know, I'll click for you because I've got all the slides together.
Thank you, Martin. So my name is Rohit Saha, and as Martin said, I am a consultant intensivist in critical care at King's, and I'm giving this talk today together with my colleague Reena Mehta, who's a consultant pharmacist in critical care. The objective of this talk, or my role here, is basically to give you a preamble, make you understand the context in which our brilliant pharmacy team did its work. And so Reena will give you a real granular insight into what they did in pharmacy, and I'll be able to give you an overview of what was happening at King's. So the fundamental problem that we encountered was that we expanded our critical care beds. So by any stretch of the imagination, King's has a very large ICU with 65 beds able to provide health or care to the sickest patients in the hospital. And over the pandemic, or over the first wave of the pandemic, we serially expanded from 65 beds up to just under 150 beds. And during all of this, there were still considerations that we would go further and further, maybe looking at up to 300 beds or so. Luckily, during the first wave, we never quite got there, and at peak we had about 125 patients critically ill in ICU. Next. And obviously all of this increased workload would bring or brought increased pressures. And I'm sure you'll have seen in the media and the news, there was a lot around the fact that we might run out of ventilators and we wouldn't be able to provide ventilators for intensive care patients. And that was a potential problem that received a lot of attention. But the first bottleneck that we encountered was actually around kidney support or renal replacement therapy. So at King's, we have the ability to provide renal support for 35 to 40 of our ICU patients. That's probably more than any other hospital across the country. And yet, early on, as we started to get more and more COVID patients coming through our doors, we realized that at some point, we might be unable and we might be overwhelmed by the sheer number of patients needing renal replacement therapy. So this graph, which unfortunately doesn't project very well, shows the number of COVID patients in our ICU, starts in mid-March and ends in June. And the patients, or the colored bars, basically show patients who are receiving kidney support. And as you can see, for our COVID patients, it starts off as a slow, gentle trickle, and this really starts to increase and take off by mid-April. And we recognized that this was going to be a problem for us. And so in conjunction with our renal colleagues, we started looking at other avenues for providing renal replacement in a way that we'd never done before. And so you can see this arrow here, we introduced another form of renal replacement therapy called peritoneal dialysis, and about 3 weeks later introduced intermittent hemodialysis. And you can see the green is the number of patients on peritoneal dialysis, and the blue is the number of patients on intermittent hemodialysis. Orange is the conventional patients on the conventional therapy that we offered. And you can see that we were able to drive down the amount of conventional renal replacement therapy, and we're using other adjuvant methods to provide renal replacement and stave off that potential for being overwhelmed. Next. The other thing that we had, obviously we expanded the number of beds, and so we had to change the structure of how we work. So normally we work within a silo. So we've got 4 units with between sort of 14 to 20 beds. And each of these units works individually and autonomously. And so you have your 20 patients, you look after them clinically, and there's not much crosstalk between units. However, so next. However, as the pandemic progressed, we started to provide critical care in more and more sites. And at one point, we were across 9 sites in the hospital. And we realized that we would need to take, instead of this very horizontal siloed structure, we'd need to adopt a more vertical structure with tactical oversight. And for this, we took a lot of learning or inspiration from the military, and were able to identify that our COVID patients tended to have very stereotyped needs. And these stereotyped needs focused around things like kidney support, transferring them from A to B, providing them with clinical care, things like proning. So you turn your patients from back to front, and that improves the amount of oxygen that they get in, and also different surgical procedures. And so every morning what we would do is we would feed up to our tactical team, and they would be able to prioritize and decide the order and which patients should receive what specific care. And this allowed our clinicians to individually focus on just the patients. Next. The other huge increase in workload came around communication. So A lot of what we do on ICU is spend a lot of time with our families, talking to them and making them understand what their loved ones are going through. Obviously, the volume of this by necessity increased because of the increase in number of patients, but also because of the changes in visitation to hospitals, our families weren't able to come in and see their loved ones. So a huge initiative that was led by a group of King's Health Partners basically sought funding for iPads and provided them to well over 100 ICUs across the country as part of the Lifelines project. And using the Lifelines project, or using these iPads, we were able to communicate with families by voice calls and video calls as well. And I think it was a hugely beneficial incentive. The other thing we did was that we realized that we still needed to make sure that the clinicians or the frontline staff could focus on delivering clinical care. And so we outsourced this communication to some of our colleagues who maybe the pandemic had made a little bit less busy. So at King's, we used dentists, ophthalmologists. I know other places use medical students to sort of drive this communication, and it's something that I think worked really well. Next. The sort of the final, or the last but one issue that I want to touch on is the workforce, and in particular the nursing workforce. And usually what happens on ICU is that our nurses have a sort of 1-to-1 ratio and look after just one patient and provide very high quality care. Especially at the beginning of the pandemic, what we asked them to do was stretch. So next, please. And by this, what I mean is that the ratios started to alter. Instead of 1-to-1 care, we looked at 1-to-2 care. I know other hospitals were looking at 1-to-3 care, 1-to-4 care. I know the Nightingale ratios were also very different as well. As things progressed, we were able to train staff from other departments, and they were able to provide some support for our nursing staff. As we're entering into a second wave, I think for me, this is probably the crucial area that we need to look at because of the huge increase in workload that we're placing on our nursing staff and the expectations that we're placing upon them and the implications of that. Next slide. So after that sobering note, I'm just going to finish up on the one positive. And we've already heard Simon Stevens talk about this a little bit. And he talked about the studies that had a huge impact on the way we deliver COVID care now. And if I'm really honest, I think this has been done magnificently well by and utilize the infrastructure that exists within the NHS and the NIHR to deliver the recovery trial. And because of the recovery trial, we now know that hydroxychloroquine doesn't work. We know that Kaletra, an antiviral, doesn't work. We know that steroids save lives. And this trial is still ongoing, well over 10,000 patients recruited into it. And we're studying things like whether immune therapy works and multiple other interventions. Next. This is just another trial or study that I wanted to flag up that I think is going to bring some real interesting results in the next few weeks. It's a study called Genomic. And again, it took advantage of the infrastructure we have in the UK, has recruited thousands of patients to try and understand why some people are getting really sick with COVID and some people are just fine. And I've seen some of the initial results for this. They've identified potential genetic targets. And maybe in the future, we might be able to identify specific genetic targets and save even more lives. So with this preamble, hopefully I've given you an idea of the context of what was happening at King's, and I'll now hand over to Reena. Thank you.
Thank you.
Thank you, Rohit. So I'm just going to give you a little bit of background about how we manage the service from a pharmacy point of view. So we deployed 25 pharmacists from all different specialities to come and get trained up into critical care. We put teams of 5 or 6 pharmacists together with a critical care specialist, and this was done right from the beginning. Every morning, the team leaders would meet up to have a huddle at about 9 o'clock, and during this huddle, they would establish the bed status. They would find out if there was any new guidelines, and they'd have an idea of what any operational issues which may have happened overnight in terms of shielding, sickness, and any other issues were being discussed. As a result, the team leaders would then meet up with their own teams and disseminate that information. So what were the challenges for us? Next. Next. Okay, so our first challenge was teaching and training. So this was for nurses, doctors, as well as pharmacists. One of our other challenges were drug shortages, thinking about medications as well as fluids. Our next challenge was opening new units. What we were finding was we were given 24 to 48 hours notice to open a new critical care unit for COVID patients. We also had to ensure guidelines and prescriptions were kept up to date during this time. Another challenge was transfer of care. This is around patients being discharged from ITU and going to the ward, and ensuring that all medications and any handover was accurately handed over to the ward staff. And one of our last challenges was what do we do to decrease the nurse workload? Next. So one of the things everybody will be able to highlight is drug shortages. We had key drug shortages in sedation agents, paralysis agents, and renal fluids. So what did we do to implement strategies to help resolve this? We put together a live daily report of stock availability. So every morning we could see what stock we had and roughly how many days we had available. And this was based on average drug doses. We also quite quickly put together sedation sparing strategies. So what was our alternative drugs we could use? As Rohit had mentioned, we also looked at using hemodialysis and peritoneal dialysis. What we found with our shortages, our larger vials were getting used up very quickly. So we very quickly put together a manufacturing process within pharmacy where smaller vials were being made into pre-filled syringes, which were ready to administer for the nurses. And all of this required us to have rapid guidelines ready for dissemination extremely quickly. Next. And together we had to share ideas, innovations, and work across our network. Next. So what did we do around teaching and training? So we split this into 3 areas. From a pharmacist point of view, we put together a mnemonic to help review patients. And this is what things they needed to think about when they looked at a patient at the end of the bed space. We also put together a pharmaceutical tool. This tool was used to look at different body systems and what needed to be monitored and considerations. We also included weekly teaching sessions as well as shadowing critical care pharmacists onto the wards. From a doctor's point of view, we made an e-learning video of our pharmacy induction, and this allowed new doctors to have an idea what the service is like, what resources are available, and what is our drugs of choice at the moment at that time. We also put together a quick reference guide of drug dosing, and this was for, again, especially doctors that don't routinely work in critical care to understand what are the drugs we use and what are the dosings in critical care. And we had pre-printed infusion charts, which allowed the doctors just to sign against the prescriptions they required at the time. It's very difficult for teaching and training for nurses as everything expanded and moved very quickly. So a lot of our training was done on the shop floor. A lot of this was putting extra pharmacy presence onto the units in order to ask questions, find stocks. And also within our pre-printed infusion charts, we had administration details, which allowed nurses to be able to find that information quickly. Next. So these are some of the things we put together to reduce the nurse workload. We moved from doing co-signing to one nurse check of most IV injectables. So we only ensure that the very high risk drugs, such as controlled drugs, insulin, potassium heparin, still were being co-signed. We also introduced dose calculation charts, especially for drugs like noradrenaline. And this is very useful for nurses that were not familiar with how to calculate noradrenaline dosing for patients. We also concentrated some of our infusions. So where we had stability data, we ensured that nurses were then having to change syringes less often, and this also saved workload time. As mentioned earlier, we introduced pre-filled syringes, which made it a lot easier for the nurses rather than drawing up ampules. And we also stopped use of patients' own drug lockers. We realised that drug security at this time was not as important as we had no public on the unit. It was literally about staff and being able to access medicines quickly. We also introduced MMPAs, Medicines Management Pharmacy Assistants, onto the wards. And this was a new concept for us at King's. And they were like the runners for us. They could go down to pharmacy, pick up controlled drugs, pick up stocks, help nurses find drugs they were not familiar with. And we found this a very useful resource, which we have continued. Next. So from an operational clinical point of view, we put together a checklist to open new critical care units, which had a standard stock list. This allowed for any area that needed to be refurbished into an ITU for any of the team to be able to follow the checklist and the directions. We supported 2 prescribing systems simultaneously. So we usually have an informatics system across our core beds, but as we expanded, we moved to paper for the new areas. And therefore, everything had to be kept updated, especially around drug shortages and new guidelines, etc. For example, we made 65 changes around for drugs over the 9-week period, and we had about 12 to 13 trials that we had to put into place and we had to configure onto the system. In order for everyone to be able to access guidelines, we introduced an app called Clinibi. This was used across our network, and this allowed any guidelines at the touch of a finger to have access to. This was an open access platform, so everybody could get access to them. And as a result, it allowed people to be able to get to the information at real time, and it was kept updated all the time. And the other big thing that happened halfway through the surge was we looked at our transfer of care to the wards, where we realised patients were going to the wards without a discharge summary and drugs were not being put on the system. So we introduced a printable drug chart, and we found that this decreased the number of drug omissions as there was always a live prescription between transfer of care. Next. So what was our learning? So our first learning was it's important to have strong leadership, have a dedicated coordinator or a clinical lead. So we had a pharmacy lead which sat within the tactical group, which was somebody who could liaise between pharmacy and the critical care division. Good communication. So this is good communication upwards to tactical and the division, downwards to the pharmacy staff, as well as across to the front line, the nurses, the doctors and HP staff on the shop floor. Resilience planning. We learnt very quickly that this wasn't just about training staff and the workforce, but it was about looking at drugs and equipment shortages and what do we need to think about, what's next, trying to keep one step ahead all the time. And the most important thing we learnt was teamwork, how important it was for us to work together, support each other, share stuff together and care for each other during this difficult time. Thanks for listening.
Great. Thank you very much, Rohit and Reena, for fabulous presentations. Colleagues, please do add your questions to the chat and we'll come back to them at the end of the presentation.